Okay, looks like it's 7 o'clock. I want to say thank you to Andy Anderson, who most of you probably know already, but he's a PhD scientist in our department who's been working in the lab downstairs on all sorts of different things. But today he's going to talk with us about form-function relationships in human joints. And he's had a lot of success in this realm recently, and we're looking forward to hearing from Andy.
Okay, thanks, Andy. I appreciate the invite to give an update on our lab's progress. And I'll just start with basically just an introduction to our research group. So our objective is really to develop, validate, and apply innovative techniques in medical imaging, motion capture, and computational modeling to advance clinical and scientific understanding of orthopedic pathology. So it's a very broad objective, but really you can kind of think of our studies really falling into three overlapping categories, which is medical image analysis, motion capture, and modeling, as you see here. And the important thing to remember is that, most of the studies that we conduct really have multiple techniques that are used, not just one of these. But so really our clinical foci are developmental dysplasia of the hip, femoroacetabular impingement syndrome, and ankle osteoarthritis. Those are really our focus. And our areas of technical expertise include biometric imaging, Dual-Fluoroscopy, skin marker motion capture, statistical shape modeling, finite element analysis, and muscle modeling. So a lot of different techniques that we use in the lab to study pathoanatomy and as well as osteoarthritis. So I think, thrust has really been looking at hip pathoanatomy and its relationship to osteoarthritis. And so we recognize that there's a high prevalence of osteoarthritis amongst pathoanatomical joints. So when we think about, in the case of the hip, developmental dysplasia, it's been estimated that 2/3 will develop hip OA within 20 years if left untreated. And then also femoroacetabular impingement, which is kind of more recently described abnormality, in which it's been estimated 1/3 will develop OA within 20 years. So I think the natural tendency is, looking at these numbers, is to say, yes, pathoanatomy causes hip OA, right? There's certainly supporting evidence for that. So contralateral mechanics, we showed are altered in patients with DDH using patient-specific finite element analysis. Very related research has shown that femoral head anatomy does affect cartilage contact mechanics, so the way that the femur is shaped. And we also know from numerous ex vivo studies that elevated stresses do reduce cartilage viability, collagen synthesis, as well as the damaged extracellular matrix. So there is some evidence against this. And so one of these is that hip deformities are very common in asymptomatic individuals without OA. And so referencing Lucas Anderson's study, which was a fantastic study done about 6 years ago now, in which they x-rayed several hips from senior athletes that are competing in the Senior Olympic Games. And out of over 1,000 hips, roughly 83% of these had FAI morphology, with most actually not having any indication of radiographic OA, which we can see here. There were actually some cases of dysplasia, but most of those were overlapping with FAI morphology. And so what's interesting is that those individuals, a little less than 20% that did have radiographic OA, 93% of them fell into the category of FAI morphology or dysplasia morphology, with most of those being FAI morphology. So it's somewhat evidence against, but it's also somewhat evidence for when you look at these overlaps. So it is interesting to see, though, however, that if you do have radiographic OA, it's pretty unlikely that you're not going to have accompanying morphology issues. So the challenge, I think, is that hip pathoanatomy is incredibly complex, and so I don't think that we have a good handle on hip pathoanatomy just from radiographic evaluation alone. So when we think about the various conditions like retroversion dysplasia, coxovalga, we can kind of classify these as hip instability. And then opposite of that on the spectrum is hip impingement. And so more typical of CAM and pincer morphology. So you might ask, okay, well, if you're in the middle, are you normal? And the answer is not necessarily, because there's combined instability and impingement. in which case we see in this particular patient, they have a high alpha angle, about 80 degrees, and borderline dysplasia at 20 degrees for the ACEA. Excuse me, LCEA. So ultimately, what we're trying to understand in the lab, at least specific to our hip research, is that, you know, in cases of instability, combined instability, impingement, and impingement, you know, which of these patients is really a good candidate for some sort of hip preservation procedure, including PAO or debridement, decompression, this is from Dr. Aoki's patient. You can see initially he's essentially removing you know, cortex down to subchondral bone, and he's using this as essentially a guide for when to stop the resection. This is a nice clean picture. This is what it looks like you know, after surgery. And so I think, you know, the other question is which of these patients is just going to progress to THA no matter what, and you know, which of these patients that's treated with hip preservation procedure is going to end up with THA fairly soon. So it's kind of a mess trying to figure out, you know, how to treat certain patients. And so the big question I have, that many of us have, is, you know, when we look at Lucas Anderson's data, obviously there's a good portion of these individuals who will continue to be athletic well into their senior years and not have any issues. So we're trying to really sort all of this out. And the way that our lab is attacking this is really kind of through two different venues. One is hip morphometrics, and the other is hip biomechanics. And so we'll start with some of the work that we're doing in hip morphometrics. So one of the problems is that radiographic measurements cannot fully describe these abnormalities that we see in patients with impingement and instability. It's been shown that alpha angles do vary considerably amongst the different views. And I'll get to that a little bit more in a second. It's also been shown that repeatability has been inconsistent. And perhaps most importantly, you know, reference standards that we're using to really evaluate different plain film measurements, these reference standards are really just still two-dimensional measurements that are made off of single images or reconstructions from CT or MRI. And so these are actually still somewhat subjective in a sense that there could be some inconsistency in defining these angles and such. So our lab has been using statistical shape modeling now for almost 8 years on the hip joint, and more recently on the ankle. And so SSMs are basically advantageous because they preserve the anatomic detail when you're quantifying and comparing complex 3D shapes. And so the way that it does this is through correspondence particles, which are placed via a computational optimization onto the surfaces. So what I mean by that is that on the left here, we have an example control, and on the right, we have an example CAM FAI patient. And what we're doing is we're putting these correspondence points. So what I mean by that is that these points are placed on the surface, and by correspondence, it's meant that they have the same ordering on the control as they do on the CAM. So when you zoom in, these dots are color coded, and so you can see, for example, you know, 2 blues, and then over here you see these 2 blues, and these 2 blues are located, you know, in the same relative spot. That's the challenge. The challenge is how do you put these points in the same kind of relative anatomic spot, especially across the population where you've got fairly large variability. And the advantage of this is that this computational optimization is implemented in ShapeWorks, which is open source and free to the public, which is developed originally in collaboration with Utah and UNC, but now it's actually pretty much Utah that's driving the bus on this. And it's a good software package. We're hoping to make it a great software package. And one of the reasons why it's good is that it actually gives you fairly accurate results. And so on the top here is basically, it's just a toy data set so that we can evaluate whether or not these different programs are, you know, how they're working. And so you can think of essentially in this toy data set, you have this bump here, and this bump is basically translating left to right across the sample. And so basically what we're trying to do is show that if you move away standard deviations from the mean, that bump also moves according to those standard deviations. And so what we see from ShapeWorks is that we can actually get that bump to translate as we want it to, and it makes sense. So when we go out, the mean -3 standard deviations bumps over here. But when we look at these other software packages, they don't really do as well at all. So you can see here, like for example, Atlas Works is essentially averaging where this bump is, and you end up getting the same result across the full spectrum. So we have applied this, as I mentioned, for about 8 or 9 years now. And so the first study was just really proof of concept to say, okay, if we analyze a population of CAM-FAI, we analyze a population of controls, when we template those group-wise differences to one another, do we see a difference in shape that makes sense clinically? And the answer is yes. So we basically can show that when we take the mean difference, that you have this bump here, as indicated by this color fringe scale. So a pretty simple study, but showing that, proof of concept. More recently, there's been a push, I think, to try to relate some of these shape modeling results to clinicians in a way that is, I think, straightforward, easy to understand, and also objective. And so essentially what we've done here is we are describing the anatomy as a single shape severity score, and we calculate this by using a linear discriminant analysis of the data. So essentially what we're doing is we're mapping individual patients to this vector, and this vector is essentially defining where the FAI mean shape is, which is right here at -1, and where the mean control shape is, which is at +1. And so you can see the individual patients here mapped along here. So this patient has a -3.2, and at -3.2, you can kind of think of that as 3.2 standard deviations away from 0. And so this patient's definitely in the category of CAM-FAI, whereas this patient here, number 27, is kind of right on the edge in terms of where the controls lie, where their standard deviation is. So this patient is not as bad. So what's nice about this is that it's objective, but it's also clinically intuitive, because it really is just a single number describing where these patients fall. And so kind of just working off of that, what we've done is we've been able to create synthetic anatomies that capture the full spectrum of data that we've looked at. So in this case, you can kind of think of it as the same sort of vector mapping, but when we look at 0, this is the average of the CAM and the control. Here's the 1 and -1 again. And what I think is pretty remarkable about this is that when you look at -4 standard deviations way on the far left, that hip is definitely CAM-FAI. You come out to +4 over here on the controls, that hip kind of looks more like a rhesus monkey in terms of the amount of head neck offset that's provided. So we think that at least I envision that this could be at some point in time in the doctor's office, and a patient would come in and we would kind of map where that patient is and show that patient, okay, you're just right about here, you're not too severe, maybe we should wait, maybe we should do PT, maybe we should do all these other things, because I'm not sure that I can really correct your anatomy, to a level that's quote unquote normal, because you're already normal. Or you're way out here, you say, look, we should move on this. So even more recent than that, what we've tried to do is essentially bring shape modeling into a quote unquote clinical journal, so that we can show that there's value in these shape models in terms of potentially changing clinical practice. And so we've really focused mostly on radiographic evaluation of FAI in this context. So as I mentioned, there's several views that have been proposed to capture femoral morphology. This is just kind of a sampling of, I would say, the more common views that are used in the clinic when evaluating at least proximal femoral anatomy. And so the question is, which view or views are best at describing the severity of these CAM deformities? And so we can actually answer that with shape modeling. And essentially what we did with the shape models is we segmented CT images to create the surfaces needed for shape modeling. And then what we also did is we essentially isolated only the femur from the CT. We made everything else around the femur black. And then using computer-controlled projections, we can actually create all the different projections that I showed in the previous slide. And then from those projections, we're actually measuring both the alpha angle and head neck offset using some MATLAB code to basically, make it easy and make it very, reduce the errors due to the human essentially showing where the alpha angle is. And so this system here, the reason why we did it this way as opposed to X-ray and all these individuals is that we could actually take the CT scan, we can align it in a neutral position, and then we can actually do computer-controlled rotations of that projection to ensure that we're getting, really consistent results. And so once we get the alpha angle head neck offset, once we get the shape severity score, which I showed on the previous slide, those individual scores from the mean, then we can actually perform partial least squares regression between those data to determine which of those measurements are most predictive of the severity of the deformity as measured objectively by shape modeling. And so what we found in this is that, not surprisingly, the alpha angle was higher in the CAM individuals than the controls for all the different views that we looked at. But when we performed partial least squares regression, what we found is that really there was only two, possibly three with a cross table, but really two that were able to be used in the regression model to predict the shape severity score. So that was the 90-degree Dunn and the Meyer lateral. And so one thing I think that's interesting about this is that when you look at these two, it's not necessarily the view that's providing the largest difference in the alpha angle that's most predictive of the 3D shape from shape modeling. That's true in the case of the Meyer, but you look over here at the 90-degree Dunn, that difference is really not that substantial. And so this is actually more evidence that built upon some earlier work that I haven't discussed, but more evidence that the difference in the alpha angle is not necessarily predictive of which hip is more or less deformed. And that's really important. So we should be just looking at the magnitude of the alpha angle and stating that, this hip is more deformed. And unfortunately, that, even with all these views to work with, the best that we could get was an R-squared of 0.525, which means that really the alpha angle is describing only about half of the variation in the true deformity that we're seeing. And what's interesting about this is that these are shape data for just the region where the CAM lesion is. It's not for the entire proximal femur. So if we're focused just on the region of the CAM lesion, we're still not very good in terms of using the alpha angle to predict the deformity. So what we said in that paper was that caution should be exercised when evaluating femoral head anatomy using the alpha angle. And we also said that there is merit in pursuing research that aims to develop the framework necessary to integrate shape modeling into clinical evaluation. And so that kind of leads us to where we're at right now. And we are actually funded now by the NIH to apply shape modeling. And I'll get to that in just a second. So this grant right here was actually the first R01 that I received in 2013. It ended around 2018. And we fought hard to get the renewal, and the renewal finally came in August of 2020. And so that's a 4-year project through the NIH. And so really the overarching objective of this is to improve the efficiency in which computer models of tissue biomechanics and shape are developed and analyzed. And so really the first goal in mind is to reduce the modeling burden. So this is a very overwhelming image, but it really is kind of why we're pursuing this, to make it more efficient. And essentially, I'll just walk you through this briefly, but in the upper left here, you've got your MR and CT data. You segment it, create these surface meshes, and for reasons I won't explain, we convert these to binary volumes, and then we have this groom phase where we're doing all sorts of things on the mesh as well as on the binary volumes to get it ready for processing. We calculate distance transforms. And once we have the distance transforms, then we get to the optimization step, which is where we're placing those particles on the surface. And there's a lot of math involved. And really, what we get to is down here is we get the correspondence particles, and then from that we can do some analysis. So this is a very complex, convoluted process that takes a lot of time and effort. So it's not as easy as just saying, okay, well, I've got this data, hey, Andy, can you create a shape model from it? There's a lot of work that's involved with that. So we want to reduce that modeling burden if we want to be able to get shape modeling, into the clinic. And so one way we're doing that is through deep machine learning, or deep SSM, and it's essentially using a convolutional neural network. And what it does is it predicts the 3D reconstruction of unseen shapes without having to segment images, which is key. So what I mean by that is that you can create a deep learning model that is built on a certain data set. And what we're showing here is 3 examples of how we're using that deep learning model to segment out to the anatomy. So this anatomy here in red has not been segmented by a human. It's been predicted by this deep learning model. And then we're calculating the difference between the actual the predicted reconstruction with the actual reconstruction. And you can see we're getting very close. I will say that these are our best images though. So there's a lot of cases where it's not, as good. And so we're troubleshooting some of those things. But what we're showing here with the unseen normal means that we have a new normal that goes into the data set, and we're predicting, what that reconstruction looks like. And then the same thing for the unseen pathological case. So we're getting close, but there's still some work that needs to be done in this. What's also nice is that, traditionally in the deep learning model, and still, you have to really use a lot of data sets to construct that model, a lot of training data sets. And, while I would say that we're approaching a couple hundred different data sets of the hip, that still isn't enough. You need thousands to do this. And so the deep SSM, which by the way was created at the Scientific Computing Institute by Shireen Alhabian, who's a co-investigator on this grant. And she's also included this novel data augmentation scheme. And essentially what this is doing is it's augmenting your data to create thousands of synthetic data sets that we then use to train the model for the segmentation purposes. But wait, there's more. So what's awesome is that this deep learning model also predicts the location of the correspondence particles, which are all those little dots that were on the reconstruction I showed you, without the computational optimization step. So what does this mean? It means that we go from this very convoluted process and we truncate it down to something like this, where you've got your CT data. The person the human would go in and essentially localize the anatomy. And what that means is that you're just saying, up is here, down is here, front is here, back is here. And once you kind of initialize that data set, then the thought at least is that this trained deep network will produce the surfaces, it will produce the locations of these correspondence particles, and then we can run through the analysis. So if we were able to go, from here to here, this would be amazing, because it would really set us up well to start running some clinical trials of using this software in the clinic. And that's really been goal 1, is to reduce that modeling burden. Goal 2, which I'll get to in a second, is to work a little bit more on the analysis side of things. So what I mean by that is that we want to implement advanced statistical methods, and our intent is to visualize, compare, and interpret these spatially varying data in aggregate form. And so our second intent is really to preserve the patient specificity of the model through statistical testing. So what I mean by that is that we spend a lot of time segmenting to create these, very kind of intricate 3D reconstructions. And we use those models for various things like shape modeling or finite element analysis. But when we get to the statistics part of it, typically what happens is that we kind of dumb it down. So we essentially divide the model into regions and average results over those regions, and then perform traditional statistical tests like linear regressions, or other tests like ANOVAs and things like that. And so it is challenging though. So this is also a very overwhelming image that, believe it or not, we actually had in a publication. We had to tuck it in as supplemental data because it was just so obnoxious, I think. But just to kind of briefly walk you through this, these are finite element contact stress results that are mapped on the acetabulum of 10 different controls, which are shown by columns here, as well as 10 different dysplasia patients for 4 different activities. So like WH means walking at heel strike, WM is walking at mid stance, et cetera, et cetera. And so I think what you can see from this is that, you know, contact stresses are very much like our fingerprints, which are unique to us. So the question is okay, how do we actually represent these data in aggregate form and make sense of these? And so what we've done historically is that we're trying to select a representative sample to display group-wise data. So we want to show, you know, what's the average dysplasia, what's the average control contact stress result. And so historically what we've done is we've taken a kind of a very pragmatic approach, I guess, in which we, for the normal, we fit all these normal acetabuli into a sphere, and then we've selected what the average of that sphere was, found the patient or the control that was closest to that average, and we said, okay, that's the average hip. We're going to map all these results to the average. We did the same thing for the dysplasia. And I think what you can see from this is that, you know, it starts to really kind of broaden out the contact stress distributions. And you see a lot more kind of low stress results here that are mapped. And that's potentially a problem because it's really difficult to make sense of some of these data when you're going from here to here. The other approach that we've done is we've subdivided the anatomy into different anatomic regions, and then we'll essentially average the results over those anatomic regions and then perform tests like ANOVAs. And the challenge with this is that, you know, obviously these are high stresses that might have some sort of clinical bearing on the development of OA, but when they straddle a boundary or when they're, you know, averaged with a lot of data that has, you know, essentially zero, it's basically washing out these results. So our proposed solution really is to use the correspondence model to visualize results over the entire sample. So what I mean by that is here we're plotting percentiles. So 0.1 means the 10th percentile up to the 90th percentile of the thickness of cortical bone that's mapped onto a single anatomy. And so what you can see here is that when we go from the 10th to the 90th percentile, controls clearly have less cortical bone thickness than FAI patients. And that cortical bone thickness is elevated in the region of the cam lesion. And so this is actually a very nice way, I think, of displaying spatial data that accompany shape. So in this case, cortical bone thickness is accompanying shape. The second step is really to apply statistical parametric mapping to identify areas of the anatomy that are different between groups by specific locations. So this was used primarily early on for fMRI research, where you're looking at, for example, the effect of a certain medication on brain activity. So you can, you know, image the brain without medication and with medication, and then you can use statistical parametric mapping to highlight regions of the brain that are changing in activity due to the medication itself. And so in this case, what we're doing is we're implementing SPM to basically show results and differences with any data, again, that accompanies shape. So in this case, cortical bone thickness, when we look at the average control and the average cam, we can actually perform SPM on that. And this is some preliminary work that Penny Atkins has been doing in the lab. And we can see the regions that are significantly different between these two. And so if you were to look at this, you could say, well, yeah, you know, the region of the cam lesion does look thicker, but what's interesting is that it's also picking up other areas of the anatomy that are significantly different. So again, the benefits of this approach is that it preserves the patient specificity all the way through through statistical testing. And, you know, we can actually look at any of these data that accompany shape, like cortical bone thickness, cartilage, stress, bone density. We can map T1 row images, all these sorts of things. So it could be a very, very good tool. So I'm going to translate now over to hip biomechanics. And most of our work in this area has been on femoroacetabular impingement syndrome and developmental dysplasia of the hip. And so right now we have funding to look at FAI. And so more recently, there was international consensus in terms of FAI, defining the condition, discussing the different treatment options, those sorts of things. And from this paper, it was agreed that FAI syndrome is a motion-related clinical disorder of the hip with a triad of symptoms, clinical signs, and imaging findings. So it's not just that you have the deformity, you have to have, symptoms as well as clinical signs. But it's been defined as, representing symptomatic premature contact between the proximal femur and the acetabulum. And so what's interesting about that is that the consensus is saying that there's premature contact, but really there's not a lot of data to support that, at least in vivo data. And so there have been some studies that suggest that kinematics are altered during walking and squatting. However, when we look at the data as a whole, a meta-analysis concluded that altered range of motion was not a characteristic of FAI, which seems to somewhat go against the concept that it represents symptomatic premature contact. So we think it's important to quantify the pathomechanics of FAI if we are to improve diagnosis and treatment. So there's different ways to investigate hip kinematics. I've shown these slides before, but just to kind of quickly go through them. Obviously, a goniometer, you can look at kinematic position at a single point in time, but it's not dynamic and it's actually quite subjective. Skin marker motion analysis is really the most common form of motion capture. It is prone to errors, especially when investigating hip kinematics, and the motion is not displayed relative to patient anatomy. And the reason why it's prone to errors is that essentially what you're trying to do is to find where the hip joint center is so that you can calculate kinematic angles and translations by looking at differences in the segment positions of the pelvis and the femur. And so when you're using the ACES markers and the PCIS markers to define where the hip joint center is, you can imagine that there's some problems with that, in that, you could be 1 to even 2 centimeters off in terms of your estimate for the hip joint center, which totally can mess up your kinematics in terms of the predictive measurement. So the other approach is computer simulations, and this really isn't so much a method to investigate hip kinematics as it is a method to kind of predict where impingement might occur. So there was some early work by Moritz in Switzerland and Dr. Beatty from Michigan. Essentially what they're doing is showing where these impingement sites are, but it's a very generic model. So here's just some work that, when you call it work that we've done in the lab, it's basically a model that's not seeming to want to work. Sorry about that. But basically the model would come up and we would show where that impingement site is. And so the issues with that is that, you've got generic kinematics. Sorry, this is going haywire. You have generic kinematics and there's really no soft tissue restraint. So it's just really where the bone hits. So it's not very realistic in my opinion. Other techniques include dynamic CT, which is not so popular because there's a lot of motion blur and because the individual is laying supine in the scanner, so it's not dynamic in terms of being physiologic for loading. Single plane fluoroscopy has also been used, but there's pretty large out of plane errors. So the approach that we're doing is dual fluoroscopy motion capture, and I'm actually just gonna switch screens a little bit because it looks like the video is not playing as it should. Just give me 1 second. Hopefully this works now. Okay, I think it's working now. So what we've done here is we've integrated our dual fluoroscopy system with our Vicon camera system, with our instrumented treadmill. So there's a lot going on here. Basically, this individual is walking such that their left hip joint is in the combined field of view of these two fluoroscopes. And we're also using skin markers to know where the rest of the body is relative to the hip joint, because we can only really see the hip joint with the fluoro system. And from the instrumented treadmill, we're actually getting ground reaction forces that we can use in subsequent kinematic and kinetic models to look at other quantities such as muscle and joint reaction forces. So really the end result of this is a three-dimensional model that's reconstructed from CT, and it is aligned in space and time. So basically these two are aligned spatially and temporally, so you can see what the hip joint is doing for this person's left hip during this gait cycle. And so how do we do that? Well, here's the left hip joint top view, which is in the combined fluoro systems. And then here are the videos. They're not great videos. I think a lot of clinicians look at this and say, boy, you know, my fluoroscope image looks a lot better during surgery. And the reason why it does is because we've modified these fluoroscopes to do high-speed data capture, image capture. And so it happens when you're doing high-speed image captures that the quality of the image goes down substantially compared to clinical fluoroscopes. And so what we can do is we can take a CT scan, we can project that to create a digitally reconstructed radiograph, which I showed earlier in the study, looking at which radiographic measurements are most predictive. And then what we can do is we can align this using different algorithms as well as some manual alignment tools. And so we align these DRRs in the fluoroscope data for every single image that we acquire within a video. So there's a lot of work involved with this. It's semi-automatic, it's not automatic. For better, looking images, the analysis itself goes a lot faster, but for the hip, it's difficult. And so we've shown previously that this technique can give you sub-millimeter bias and precision, as well as sub-degree bias and precision. So more recently, we've applied this in a cohort of FAI patients as well as controls. This was published in JOR last year with Penny Atkins as the first author of this, or excuse me, 2 years ago, with Penny Atkins as the first author. And so the methods essentially, here's our 7 patients and 11 controls, and we're doing dual fluoroscopy during these activities here, which includes standing, level treadmill walking, and then we incline the treadmill to 5 degrees. And then we also did pivoting, kind of like a golf swing where both feet are planted and you're just pivoting in and out. And so when we look at the results, what we found is that just during standing itself, the CAM patient stood with the hip extended, while control subjects had a little bit of hip flexion. So here's that negative angle indicating extension. And then here's the patient angle of about 5 degrees of hip flexion when they're standing. We also found that patients stood with less anterior pelvic tilt. And so when we think about what this means is that, with equivalent femur position, an increase in anterior pelvic tilt will actually serve to create hip joint flexion. And so when we look at this, this is anterior pelvic tilt on the left, and then on the right is kind of more of a neutral or posterior pelvic tilt. So this would be kind of more represented on the right of how CAM patients are standing. And so we think that this means something, but we don't exactly know what yet. When we look at the results, we found no difference in gait speed or cadence between the groups. There's no difference in internal rotation for any of the activities, which is interesting because we kind of think of CAM FAI as a restriction in internal rotation. Increased hip flexion in patients, which is only really during the pivot activity. And when we look at kind of the dynamic kinematic data, so on the left, we have flexion extension, abduction in the center, and internal external rotation on the right. We did see, patterns of increased hip extension and external rotation for both of our walking speeds, as well as incline walking. And more specifically, you can see here kind of at the peak during the middle of the gait cycle, there's a little bit more extension in the CAM group shown here in red. And you can also see on the far right here that there's slightly more external rotation during gait for the CAM group. And then when we looked at peak external rotation, we saw that there was differences here during level walking during peak external rotation shown by the asterisk. But really there was no significant difference in the total range of motion, so max minus the min. But you do actually, when you look at these data, you do see a shift in sagittal and transverse plane kinematics. So flexion extension as well as external internal rotation. The pelvic data was also interesting. So we see that there was wider intersubject variability of pelvic tilt angles. So we have anterior, posterior tilt, obliquity, as well as rotation shown here in the 3 panels. And what we can see is that there's considerable variation amongst the CAM participants in tilt. But when we actually look at how much their variation is in internal external rotation, it's very, very tight window that they're operating in. So they're kind of sloppy, I think, in tilt, and really not sloppy at all in internal external rotation. So as kind of an extension of that study, we are also interested in this concept of hip instability. So this was published as an abstract in the ASB meeting last year, and we're working right now on converting this to a paper that we're going to submit to AJSM. And the motivation behind this is we think of instability as extra physiologic motion. There's multiple etiologies as shown here, but there's really limited data in terms of what it means for the hip. So in terms of quantitative data. So Sato et al. Measured about 1 millimeters of translation in dysplastic hips and about half of that in normal hips, whereas other reports suggest that there's 2 to 5 millimeters in normal hips. So nobody really knows what's going on in terms of what the actual kind of normal instability is. Instability can be caused by impingement. So we kind of think of impingement as restricting normative motion, but based upon some of the clinical symptoms of motion-related pain, clicking, catching, and popping, there is some evidence that impingement does cause instability, but no prior studies have actually measured instability in patients with impingement. So that's what we set out to do, and we used the same data set as I talked about in the last study. Here we're focusing on level and incline walking only, and essentially what we're doing is we're quantifying the distance between the femoral head bone and the acetabular bone, and then we're to get kind of an average instability value, we're defining it as a change of distance in that bone-to-bone distance, where you take the maximum of the minimum distance over the gait cycle and you subtract the minimum of the minimum distance over the gait cycle. Kind of confusing, but that's just our way of getting kind of a single value for instability. And we have not implemented SPM yet, fully into the lab. So in this case, we're actually regionalizing the anatomy for statistical comparisons. And so I'll show you a video here, and what I want you to kind of look at is on the left, we have a representative patient. On the right, we have a control. This is a plot of the bone-to-bone distance between the femur and the acetabulum, shown relative to just the acetabulum. And then we're actually having these videos here will kind of guide you in terms of where this hip is and this hip is in terms of the gait cycle. So I think what you're going to see is that for the patient, there's more wobble. So we see kind of more variation and fluctuations in this bone-to-bone distance than we do for the control. We also see kind of a consistent decrease in the posterior bone-to-bone distance for the patient. So I'll just play the video. And here we're getting to about mid-stance. And again, you can kind of just see there's a lot more fluctuations going on in the patient than on the control. And then this goes back to heel strike again right here. So when we look at this in terms of, graphically, when we look at the measure of instability as a single value, blue is the CAM, red is the control, and then here's our different anatomic regions. And then when we run statistics on this, we see that there was an increase in instability amongst the patients in the superior, posterior superior, basically all the regions except the anterior superior region, which is really where I think most of the action is in terms of our kind of historical idea that impingement is occurring in this region. It does seem to be that there's instability amongst these other regions. So there are some limitations of these studies, obviously a lower sample size, but I guess I would say that these sample sizes have been sufficient in that no other, a group really in the world has been able to do dual fluoroscopy on native hip joints in the way that we have. So these were great studies in terms of proof of concept, generating the hypotheses that we need, as well as supporting submission and funding of multi-year project grants. The dual fluoroscopy system is very constrained. It's awkward setup. It takes a long time to set up our system. And in the case of using two fluoroscopes, our individuals are walking with their arms raised. So obviously that may alter regular gait. And this constrained system kind of puts limitations on the activities that we can feasibly look at. Of course, exposure to ionizing radiation is a concern. I will note, though, that the CT scan really represents 80% of the total radiation burden for our studies, and we're actually using up to 3 minutes of fluoro time. I don't think we've gone that high, but we do have approval to go up to 3 minutes. So really, the CT is the offender here in terms of the radiation burden. And then, we're not really considering chondrolabral tissue mechanics, which is important, because that's where we think, when we have altered chondrolabral mechanics is where we see damage, which, instigates OA. So the next steps for addressing these limitations are an R1 that was funded in July of 2020. So I think, unlike most people, 2020 was a great year for our lab, and for me in particular, in terms of securing funding, but it was really work that was done in 2018 and 19 to get to that point. And so the objective of that study is to advance understanding of FAI pathophysiology through rigorous evaluation of hip biomechanics and morphometrics. And so really the motivation here is that we think that shear stresses causes fissures and delamination, and that strain causes fibrillation and tears. But also, there's some thoughts that instability is causing chondrolabral damage as well. And so when we kind of think about this, as you rotate a spherical head inside the socket, it's not going to really have a huge bearing on chondrolabral stresses. But when you make that head aspherical, you can imagine that as you rotate that, you're displacing the labrum and you're causing shear stress at the chondrolabral boundary. But also you could envision that there's some translation that's occurring as a result of this impingement. And so we do see this, this is a patient that Dr. Peters did several years ago as an open debridement case. The femur's already been corrected, but you can see this really large delamination here of acetabular cartilage. And so we want to understand, how the anatomy is really causing that, if it is at all. So this is the workflow that we're using. In this particular study, in the past, we've actually screened our controls and omitted individuals that have abnormalities. But now we actually want to include them because we want to better understand form-function relationships. So we both have a negative and a positive control group, a patient group, CT or MR arthrography, dual fluoroscopy, and we can reconstruct the soft tissue and bone models. We perform tracking, we get the kinematics, and then we feed this kinematics into OpenSim to get muscle force predictions that we then use for our contact models down here. So one of the prerequisites, I think, to getting this study going has been to address chronic equipment headaches. And so we have done that, which is great. So it's from the movie Office Space. It's one of my favorite movies. And this is really Heath, myself, and Amy that are going to take the fluoro system out to a field somewhere and make sure it disappears. Because happy St. Patrick's Day, by the way, to everybody, because the leprechauns of Kent and Serena were able to negotiate a large sum of money from the VA to support the construction of a new fluoro system, which is shown here. We were so close to getting it done, and then when COVID hit, we had a lot of constraints in terms of finishing this project, but it's done now. So the advantage of this system is that we have larger image intensifiers. They're much more maneuverable. Our x-rays are mounted to the ceiling on gantries, so we can move this around very easily. It's a very nice system. And so here's an example setup for Heath's R01 shoulder study, where he's looking at kinematics of the shoulder for different activities. And the setup itself is so much easier. So the second prerequisite is to reduce the radiation burden. And so when we think about what radiation exposure is, round trip flight New York to LA is quite low. Annual background radiation is about 3 or so millisieverts per year. Our HIP study is about 11 to 12. And so when we think about, cancer risk, it's about 100 times that when there's a significant increase in cancer risk for this is accumulated dose too. So our goal is to bring this down. And the way that we're doing that is predominantly by eliminating the CT scan. we're doing a 3D DES on a 3T magnet. We're using a pink pad per Travis's recommendation to apply traction. And so we do that during the MRI using a custom weight and pulley system as well as the pink pad. And we piloted this whole protocol during a Pac-12 funded study to look at shape modeling of athletes. And we get very good visualization of bone, no doubt about it. So here's a female collegiate soccer player. We're getting 0.7 millimeter isotropic images. And we do get excellent visualization of cartilage and labrum in select individuals. And so this is not a arthrography. There's just a lot of fluid in this individual's hip joint. She does have borderline dysplasia, which I think played a role in the ability to get good traction on her because it was already, I think, a little bit unstable of a joint. But we think that by using ultrasound guided arthrography, once we actually inject some contrast in here, things will go a lot better. So we also need to create CT-like images for tracking with the dual fluoro data. So here's an example where we're taking a T1 weighted image, and then we're transforming this to kind of look like a CT image. And then we're using that as part of the dual fluoroscopy registration procedure, and it actually works quite well. So I haven't forgot about the ankle. We're doing some ankle research as well. We're a little short on time, so I'll kind of rip through this. But we had a R21 study that went from 2017 to March of 20. And our objective here was to quantify and compare in vivo articulation of the primary ankle and adjacent subtalar joint using dual fluoro in patients with arthrodesis, total ankle replacement, and a control population. And so the clinical problem here is that, arthrodesis provides pain relief, but many patients aren't able to do the same activities they were before. There are still non-union rates of 10 to 15%. And perhaps most importantly, there's really a high rate of secondary subtalar OA within 20 years after surgery. TAR, preserves motion at the tibiotalar joint, which theoretically should decrease compensation at the subtalar joint. However, it has a fairly high revision rate at 10 years. And, many of these patients are converted to arthrodesis due to limited bone stock. So overall, there's a tendency to avoid TAR in younger patients, yet, these individuals could perhaps benefit the most from having that function of motion provided by total ankle replacement. So there's some technical challenges with measuring ankle motion and kind of think about marker-based motion capture. The issue is that you can't separate tibiotalar motion from subtalar motion. So what you're doing with a skin marker-based model is you're representing the tibia and talus as a single segment, and then the calcaneus as a part of the segment. And so can't differentiate those two. There's also issues in that you're displaying kinematics relative to generic anatomy, and it is sensitive to soft tissue artifacts. So as the skin slides, the marker slides, and you get inaccurate results. And so we need a better method to independently measure tibiotalar motion. And so there's been a different way to do this. One is actually implanting beads into people and tracking bead positions with fluoroscopy. The other is, I would not want to volunteer for this study, is bone pins where there's a triad of markers that stick out. So this literally is going into individual bones. And this person's walking to get motion of the subtalar joint. Obviously, there's issues there. Single plane fluoroscopy has the same issues as the hip, where you get out of plane motions. So what we're doing is dual fluoroscopy, and this was done on 10 patients with a unilateral fusion and 6 patients with TAR using the Zimmer trabecular metal product. And then we had 6 controls, and our activities were over ground gait as well as a double heel rise, where you're just kind of rising up to your tippy toes with both feet balanced. This is our fluoro system here. It's embedded into the floor so that we can look at the motion relative to these force plates, Vicon cameras, kind of the same setup as the hip joint. So I'll just kind of run through this because it's very much the same methods that we have for the hip, but basically we have dual fluoro, CT, and then this markerless tracking. These are the fluoro videos for the patient with TAR. So one of the issues has been metal artifact from CT with the TAR group. So Amy led a very nice study that developed a new methodology for essentially resegmenting the anatomy to account for this metal artifact. And so essentially what's done is that you do an initial segmentation and then you bring in the CAD geometry of the implant itself, and then you use that as a guide to kind of fill in the areas of bone that you've missed due to metal artifact. And this turns out to be essential really for tracking with dual fluoro. So when we look at these results, we can see that TR versus untreated is actually very similar for the plantar flexion, inversion, eversion, and internal external rotation. It's actually similar to controls with only slight differences here during late stance. And then the untreated side is also fairly similar to controls. For the double heel rise, we actually start to see a little bit more significant differences between controls and TR patients, but this is a pretty hard activity to go up to your tippy toes. And so we were still actually pretty impressed with the fact that TR was able to do so well. When we look at the subtalar joint, these are the results. We can see that TR is not really changing subtalar joint motion that much at all, but when we look at the arthrodesis, we see much more significant differences, especially during the early part of stance. And then this is arthrodesis versus the untreated side, and then the untreated side versus controls. Similarly, for the double heel rise activity, we can see the subtalar joint is doing quite well, actually, no differences, whereas arthrodesis is causing a lot of changes to the subtalar joint during this double heel rise activity. So take-home points for arthrodesis is that, you know, we do see compensatory motion at the adjacent subtalar joint. There is asymmetry in subtalar kinematics between treated and untreated sides. But for TAR, it was near normal joint rotations, minimal disruption to kinematics of the subtalar joint, and nearly symmetric tibiotalar and subtalar kinematics. And so really what we're thinking is that it's unlikely TAR failures are due to abnormal kinematics. So limitations in terms of the ankle, complex and labor-intensive process. And so kind of the antidote to that is to do deep machine learning to expedite segmentation and tracking. All of our work was cross-sectional with no pre-post comparisons. And so we're thinking longitudinal analysis to study the adaptation of the subtalar joint. And then finally, you know, ankle morphology is highly heterogeneous, especially amongst patients with OA. And so our goal is to characterize form function relationships using statistical shape modeling. We did submit an R01, myself, Charlie, Alexi, and Amy, as well as Shireen, in October. That R01 did not score well, but we're gonna retackle it again in the future. So with that, I just want to acknowledge my many people who have worked in the lab as well as my funding sources. Thank you.
Andy, that was great. Congratulations on the recent funding. And I had a question for you. You touched on this a little bit already, but especially with your hip biomechanics work, what the end point of all this, what would be your ideal translation into the clinic? How would this affect patient care?
Yeah, I think it's important to really define, which aspects of the anatomy are contributing the most, I would say, to deleterious mechanics. And so our goal really is to establish those form function relationships. My postdoc, Joe Mazingo, actually received funding from the NIH as a postdoctoral fellowship. And the goal of that project is to essentially look at the kinematic data and look at the shape data and make those associations between one another to better understand, that from the kinematic side. And we hope to do something very similar once we collect all of our fine element results as part of this R01.
Great, thanks. And then we have a few minutes for a couple of questions. Time is brief, but I'll open it up now for anybody else. Okay, looks like we're about 8. Again, congrats, Andy, and thank you very much for a great lecture.
You're welcome. Thank you.